It's a pleasure to be on this panel. I'm Dr. Andrea Pusic. I'm Chief of Plastic and Reconstructive Surgery at Brigham and Women's Hospital and Director of the Patient-Reported Outcomes Healthcare Value and Experience Center, PROVE Center at Brigham Health. My comments today will focus on patient-reported outcomes and how we can use patient-facing digital applications to engage and support our cancer patients. Patient-reported outcomes are those aspects of outcome that only patients can know and tell us about, such as symptoms like pain and aspects of quality of life like physical function. And clearly in oncology, we've come to appreciate the importance of PROs. An example would be in how clinical teams are better able to understand and manage patient symptoms. In the current paradigm, we use digital applications to collect PRO data from patients. What I think is a particularly new and exciting opportunity, especially in light of the pandemic, is the opportunity to use patient-facing digital applications to monitor PROs and to actually provide direct feedback and resources to patients. I'm going to provide you with two examples, one from my previous hospital, which was Sloan-Kettering Cancer Center in New York, and one from my current hospital, which is Brigham and Women's Hospital. In 2016, MSK opened a new ambulatory cancer surgery hospital with a view to moving about half of the ambulatory surgery volume to this new facility. In setting this up, we recognized that while there be many advantages to shorter hospital stays in ambulatory surgery, this could potentially also put some increased burden on patients and their families. They wouldn't have 24/7 nursing care, they wouldn't see their doctor every day, and effectively they'd be asked to manage their recovery at home and self-monitor their symptoms and reach out to us if they felt that they were experiencing worrisome symptoms or something was going wrong. The problem is patients don't always know that, and that can create some anxiety for them and potentially put patients at risk for an adverse event if something is happening that they're not recognizing as something they should reach out to us for. So we worked to set up a system to be able to monitor our patients after they left the facility, and we called this the MSK Recovery Tracker. Effectively, patients were asked to answer 11 questions. These are PRO-CTCAE items, 11 questions every day. It would take about 2 to 3 minutes. And from their answers, the answers would move into our algorithms, which would allow us to see whether a patient was trending off in terms of having increased severity of symptoms or something that was potentially worrisome. And then this would generate an alert to our nursing teams who could reach out and call the patient. So this system was actually really successful. When we looked at from before and after the launch of this program, what we saw was about a 30% decrease in the number of ambulatory surgery patients coming back unnecessarily to our urgent care facility, meaning they weren't admitted, they were sent home, and basically things could have been dealt with with a phone call or a clinic visit. So that was a real positive, not just for the hospital in terms of our urgent care, but also for patients, because going to the urgent care center when you don't need to be there can be an unnecessary stress. The downside to this, however, was it did create a lot of phone calls for the nurses. And to the credit of our nursing colleagues, they stepped up and were eager to help with this initiative. But we realized that it did limit the scalability of a program, say, beyond institutions like MSK, where we could have such a large team of nurses fielding these different phone calls. So that we got thinking, well, what can we do as a next step? Could we potentially, instead of just making phone calls, was there a way to potentially give patients more information and autonomy to help them better interpret for themselves how they were doing? And this, I think, is where it got really interesting. We did is working with our patient partners and also our really great IT team. We used the data that we had collected on patients in the early time of the program, and we developed these reports for patients. So effectively, patients would complete their 11 symptoms, they would hit submit, and a report would come back to them. And so this is an example of a patient who's had bilateral mastectomy surgery. She's reporting moderate pain 4 days after surgery. And the report about her pain says, you're reporting moderate pain. Moderate pain 4 days after surgery is expected, nothing to be concerned about. Furthermore, we're able to tell her how that she's actually experiencing less pain than might be expected. And this is based on the normative data from other women who've had bilateral mastectomies performed also at the same facility. And we were also able to track her over time. So if you look at the graphic down below, the dots are our patient, and the line is the data from other patients just like this woman. So she can also see what she can expect over the coming week over time. And what we saw is that in parallel of developing a system, we also did a lot of qualitative work trying to understand what the patient experience was like through this. Before we had anything in place, before we developed Recovery Tracker, what we were hearing was, I worried about everything. I was looking always for problems. So that idea of like, I'm feeling symptoms, but I don't know if this is okay or not. After we developed the Recovery Tracker, what we were hearing was, I felt more connected and cared for a longer time period. This idea that I've left the facility, but someone's still watching me, someone's still monitoring me. And then following that, once we put these enhanced feedback reports in, the qualitative data that we were seeing was I felt more in control. Like I didn't have to just wait and wonder if everything was okay. So I wasn't just waiting for the phone to ring for a nurse to tell me I should come in. So very well received from patients. We then, with support from PCORI, we studied this. And so with Dr. Larissa Temple and help from Dr. Brett Simon, we performed a randomized trial. We've just wrapped this up. We randomized 2,600 patients to either receive the enhanced feedback or nursing phone calls. And as I said, we just wrapped this up, so I can't share all of the data with you. We're in the process of analyzing it. What I can tell you is that we did not see a difference in urgent care visits or adverse events. The urgent care visits, not seeing that decrease, makes sense, I think, because we really saw the biggest drop there when we instituted a system of monitoring, period. What we did see, which was both positive and not unexpected, was a decrease in nursing phone calls in the group of patients that were receiving the feedback reports. So what we saw was 0.4 fewer calls per patient if they were receiving the feedback reports. And at MSK, this is actually clinically very significant. So MSK performs about 10,000 ambulatory cancer surgeries a year. So 0.4 fewer calls per patient represents 4,000 fewer phone calls for our nurses to make. We're now in the process of looking at our secondary endpoints of patient anxiety, engagement, caregiver burden, and I'll be looking forward to reporting back later in the summer or fall regarding those endpoints. So switching tracks to the work that's now happening in Boston, this is really building on lessons learned at MSK, but thinking beyond the perioperative period, but also into longer-term survivorship. And here we're working to build creative new software solutions that, again, provide feedback to patients, not just about the perioperative period, but how they're doing in their longer-term survivorship. And the concept is that we can support our patients, maintain our connection with them through tailored assessment, feedback, and links to resources. All of this work predates the pandemic, but I think it actually is particularly important right now to us as we're looking for ways to decrease inpatient burden, move to more virtual care environments, and also contain costs. So as an example, you can imagine a patient, a breast cancer patient who's had perhaps an axillary node dissection and had radiation, and over time she may experience decreasing arm mobility, decreased physical function. So by reporting her PROs in the improved system, she would receive feedback about this and links to tailored resources about things that may be helpful to her. And so the idea again here being is that these are things that we can offer to our patients that has the potential to improve their experience and their outcomes while at the same time decreasing the drain on the system in terms of inpatient visits, in-person visits, and costs. So in conclusion, I think patients can be engaged to not only report their PROs, but can receive tailored feedback and resources. And patient-facing digital applications that can do this have the potential to improve patient experience and outcomes without increasing resource utilization in terms of, say, personnel and nursing phone calls. And that this is a particularly relevant concept or idea given COVID-19 constraints that we're currently experiencing on inpatient visits and healthcare costs. Thank you.